Thank you in advance. So today we're just going to talk about HIV diagnosis and care. The bulk of my talk will be on diagnosis, a very small aspect of it on routine care of HIV in general practice. And we talk a little bit about epidemiology and what it means for migrants to suffer from HIV. So our learning objectives for today. So yes, what it means to be a migrant and live with HIV in the UK. It's a bit optimistic here for me to state I want you to become confident and competent in recognizing signs and symptoms associated with a HIV infection and offering an HIV test in a non-judgmental way. But nevertheless, we're going to try it. And then, right, all you need to know about the CD4 count. Any idea what a CD4 count is? Has anyone heard of it? Okay. Well, CD4 count, the CD4 cell is a T cell that carries the CD4 receptor. That's the door handle the virus uses to get into the cell and infect it, and eventually kill it. And these T cells, the CD4 T cells, are the one that sends the foreign invaders, like HIV, to inform everyone else in the immune system to fight the infection. So the normal range is between 500 and 1,500, and the CD4 less than 50. These days we consider as an indication for people to start their antiretroviral treatment. And if you have a CD4 of less than 200, that is one of the definitions of AIDS. So the fact, HIV these days is no longer a life-threatening disease. It's more considered a chronic treatable medical condition. However, there's quite a big discrepancy in kind of what we specialists and people who live with HIV know about it. And on the other hand is the enormous spread of the continuing spread of HIV in the UK. In 2010, HBA data, a bit less than a quarter of patients did not know they had the infection, and half of those were diagnosed late. And really, our role here today is to focus on those, to identify those who. I'm not sorry, is this the wrong button? To identify those that are undiagnosed. And I believe in general practice, we have the patients and we have the scope to undertake testing. So what are the dangers of late HIV diagnosis? First of all, you have a 10-fold higher chance of dying within the first year of diagnosis. Secondly, your life expectancy is 15 years lower in those who are being initiated, who are being started on their treatment late, as opposed to those who are being treated on time. There's an increased risk of unwitting onward transmission due to continuing risk behavior and high infectivity, particularly in the early stages. And then you're also less likely to respond to medication. So the benefits of testing and being diagnosed early means you will be able to see a specialist early, you will receive prompt treatment, gives you a chance to notify your partners, you will receive psychosocial counseling. We also know that as people who know their HIV status are more likely to practice safe sex and protect their partners. This is quite an interesting study that has come out in 2011. It's an international study done in Africa, the Americas, and in Asia on 1,700 patients that compared two treatment groups. One group where people were started on time for HIV, and then those were compared with a late treatment group. So this was a CD4 less than 250. And just by doing that, the people in the treatment group had a 96% lower risk of catching HIV. And then, of course, there is a big topic these days, healthcare costs. We know that for any single case prevented, we would save around £300,000 in life treatment costs. Just a few graphs to highlight the problematic of the situation of HIV in the UK. Just focus at the red line, which is the patient's new diagnosed in a particular year. So, you know, HIV, the first test developed in 1983, and then, you know, flatlined for quite some time until the late 90s, 1999. That's where the diagnosis really shot up. And this is mainly due to the decision to offer an HIV test as an opt-out, in an opt-out fashion in the antenatal clinics. And then 2 years later, there was also extended to GUM clinics. And then since 2007, there has been a sharp decline, well, a relatively sharp decline in new diagnoses. So why is that? Well, it's mainly due to less HIV acquired overseas or imported HIV. But if you, for instance, if you look to cases diagnosed in the UK, it continues to spread amongst men who have sex with men, and then also alarmingly amongst heterosexuals. So the figures of kind of UK-born HIV continue to rise. And this is just to demonstrate who carries the bulk of the infection. It's mainly men who have sex with men, but then also second, it's people from sub-Saharan Africa. So, so in terms of people from sub-Saharan Africa, so what would be typical for them in terms of HIV? First of all, they're more likely to be heterosexual. They are the ones who are being diagnosed very late. 63% of those at diagnosis have a CD4 count of less than 350. And then HIV is only of the many problems. You know, they have migration, asylum concerns, high level of unmet social needs, then also high level of stigma within both the African and the host communities. And then the notion also that HIV is a terminal illness elsewhere, so kind of not the acceptance for patients, or the not knowing for the patient for HIV to be a chronic treatable medical condition. Then also for those on the asylum process, seeking process, is the fear of withdrawal of therapy when they have to leave the country, in case they have to leave the country, or treatment not being available back home. So this is just quite an interesting, fascinating read, actually, that has just come out recently, which looked at resilience factors in people in asylum seekers living with HIV. So they argue that, and that is from interviews with asylum seekers in volunteer services. So the main stresses, as mentioned earlier, is leaving behind many resources, the stigma I've mentioned, but also being trapped in the asylum-seeking process. But however, patients are resilient in terms of they define it as being acting positively if some things go wrong. That's how they define resilience. Staying busy, intellectually busy, personal faith, that's faith in believing God, and then also very importantly for us healthcare professionals, they very much draw on the support from HIV care providers and the voluntary organizations. And then just one slide on the other vulnerable group, that's migrants from Eastern Europe. They only form a very small number a very small proportion of patients with HIV. It's only 1%, they only make up 1.2% of all cases new diagnosed. They mainly come from countries where HIV actually is not such a problem. In fact, the prevalence figures there are a lot lower than in the UK. So their risk of catching HIV is in the UK. And that is because they have a lot more partners, they are younger, they have a lot more partners, a lot more clients, they're less likely to use contraception, and then they don't really use the access to GP services. So HIV in the UK, so that's where the hotspots are, of course, is so London. A high prevalence area in the UK is defined as an area where there is 2 or more per 1,000 patients living with HIV. So these areas are London, of course, and then the metropolitan areas, Birmingham, Manchester, and Edinburgh. And these are just the figures, so that the PCT figures. So the top PCTs in the country, Lambeth with 13.3 cases per 1,000, central London, and then this is Hackney, that's where we work. Just briefly on the way we think about HIV testing and diagnosing. Principally, there is diagnostic testing, so that is a patient comes in with a symptom suggestive of HIV. We call it diagnostic testing. We'll have a look at that in a second. Opportunistic testing is offering an HIV test to someone who may be at risk, that is, to men who have sex with men and people from Black Africa. And then opt-out routine testing is more on the screening side. So the natural HIV infection of HIV, so this is the CD4 count plotted against the infection, the duration of the time after infection. So if you just look at the CD4 line, it usually drops initially, the CD4 count initially drops following infection, drops slightly, in some people significantly, weakening someone's immune system until it recovers within 3 months, and then for it to drop continuously over the next following 5 to 10 years. And if left untreated, that person may eventually develop symptoms of AIDS. Diagnostic testing. Okay, let's just do a case together. So we're looking at the 25-year-old female Black African patients who comes in with a 5-day history of fever, aches, and pains in muscles and joints, sore throat, sweating at night. She's just returned from Zambia, and she says, well, she's been taking her malaria medication. So let's just, for the simplicity of things, just let's forget about tropical diseases for now. And then you just send her home, explaining to her this is a viral illness, advise symptomatic treatment, and to come back better, if not better, in the next 3 to 4 days. And then she calls you 10 days later that she's feeling much the same and feeling drained. And then she also noticed the rash affecting her body and face. So what happened? Any ideas?
How's the rash?
So, how's the rash? So I didn't understand that.
Put a glass on it.
Oh, that's a good one. Put a glass on it, yeah. Okay, someone presenting with a viral illness and the fever. This is a presentation about HIV. What could it be? Anyway, primary HIV infection. Primary HIV infection. There's a lot of people out there, they say, well, there's no way for anyone to diagnose primary HIV infection because it's just, it's a flu. But I argue that is not necessarily the case. First of all, yes. I mean, some people won't develop any symptoms following infection, but up to 80% do. Secondly, following an incubation period of 2 to 4 weeks, most patients will develop a glandular-like fever, usually lasting 1 to 4 weeks. Fever, myalgia, rash, headache, sore throat. This is from the British HIV Association. Some may present with a predominantly gastrointestinal disease, so abdominal pain, diarrhea. But interestingly, up to 50% will have a convalescent phase, including lethargy, malaise, low-grade fever lasting for months. So the point I'm trying here, there's two really points I'm trying to make here. First of all, the duration, in comparing it with a flu, the duration of the illness tends to be longer. It tends to last longer than a week. But that patient, she called us. She was still feeling better. And then secondly, the convalescent phase. So this is when all the acute symptoms have settled. That person calling you, listen, I'm totally drained. There's something wrong with me. Doctor, tell me. This might be HIV. Okay, differential diagnosis, drug reaction, glandular fever, syphilis, and so on. This is a typical rash for patients with primary HIV infection. It's patches on the skin of the forehead and the trunk, not so much the arms. And then secondly, some patients also present with genital ulcers. Or, I saw a chap the other day, you can barely see it here, in my surgery who came on with a spot exactly like this one. That's why I put the photo. His HIV test was negative. Okay, so what could we have done to prevent this case from being missed? And I would like to refer you. We won't be able to go into asking for or consulting about HIV in very much detail. What I would like to do is refer you to this excellent resource here. There are some hard copies outside available for people to have a look at from the MedFesh, the Medical Foundation for AIDS and Sexual Health. It's a leaflet written for GPs. And then basically what they recommend, for instance, in a situation like this, how could we ask the patient, an illnesses like this are usually caused by viruses, for example, the glandular fever flu virus. Some that's not quite right. Some viruses can be a cause, and it is important. I don't list them if they occur. I don't know if you're at risk, but HIV is just one of them. Okay, case 2 continued. So that person, that same lady, comes in again 2 years later to see you. This time she presents with a chest infection. She has crackles in the left lower zone. They give her amoxicillin. Chest X-ray shows signs of consolidation in the left lower zone. Another 3 years later, receive a discharge letter from the hospital, admitted with severe pneumonia. And then you spend a little time wondering, what happened to her over the last few years. And then you realize that she'd been attending your surgery on several occasions for fatigue, weight loss, and changes on the skin over the last 6 months. And secondly, you also notice that she had a neutrophil count her neutrophil count was low a couple of years ago. She turns out to be HIV positive, diagnosed very late. What happened? This is based on the real-life situation. Right. This patient presented late. What I also would like to share with you is so in a way, this patient was missed on probably there were 3 opportunities missed for diagnosis, for diagnosing her having HIV. Just to remind you, first of all, when she presented with the acute primary HIV infection, secondly, when she was found to have neutropenia, and thirdly, with pneumonia. So we undertook a kind of occasional review in Tower Hamlets, in 4 GP surgeries in Tower Hamlets, to look at missed opportunities for diagnosis. So we looked at all patients known to the surgeries. It was a total of 112. 40 out of those were diagnosed registered with their GP. 10 out of the 40 were diagnosed by their general practitioner, so that's 25%. That's good. However, there were an additional 8 patients where the GP considered HIV testing, but didn't do it. Why is not clear to us. I mean, it could have been, it just may mean discussion has taken place, but the GP didn't react on it, or patient didn't want it, so there were no more details available on GP, on the notes. In terms of the indicator conditions, so we also looked at indicator conditions in the 3 years preceding diagnosis. 60% of patients presented with a HIV-associated illness in those 3 years preceding their diagnosis. It took about 6 months from the first indicator being detected to the time of diagnosis, and people presented in an average of 4 times from the first indicator condition to diagnosis. So people come in repeatedly before there's something wrong with them. Their immune system keeps deteriorating, they start becoming ill, and then and that's why they come in to see you. Previously healthy and well. So these are the indicator conditions we found. So indicator conditions, again, these are illnesses that are associated with HIV, and which emerge particularly when someone's immune system starts to deteriorate. So pneumonia in the surgeries was the most common cause. That's pneumonia. It's just pneumonia. Neutrophilia, just change. It could be anemia, thrombocytopenia, or neutropenia, or a candidiasis. A flu-like illness, 5 of those. Sexually transmitted infections, we have to offer everyone who's been tested diagnosed with chlamydia, we've got to offer them, or any other sexually transmitted infection, they've got to be offered a HIV test. Problems with their skin, and so on and so on and so on. And then look at this, Kaposi's sarcoma. So these are the really rare ones. Then there's another audit that has just come out recently. It's done by the British HIV Association themselves, and they basically showed exactly the same picture. So it's all these illnesses that are commonly seen and diagnosed in general practice. They additionally found, and that was the most common cause, chronic diarrhea, weight loss, TB, hepatitis B, C, and then a SIN2. And then it's a long list of things. You can find it at the BEVA guidelines. There's an additional 28 indicator conditions. So how could that have been prevented? For instance, those 2 years further on, when this patient was found to have neutropenia, that's what I ask my patients these days. And then the other day I had, one lady from East Africa, and then I noticed her having a low neutrophil count, and then I just said, well, listen, this is we see that in a lot of people. It's a normal finding in a lot of people. Some may indicate they have HIV. Would you be interested in having HIV? She interrupted me and said, listen, doctor, my previous GP has already asked me about this. Now, they did the HIV test and came back as fine. Okay, and then also asking how to approach people. It's a very delicate issue, isn't it? I mean, how do I approach someone who is from Africa in terms of HIV testing? How do I go about offering the test? Again, MedFash gives us some very good guidance here. They, for instance, suggest, this would be one way to say it. There's a lot of HIV in your home country, I think. Do you know anyone who is affected? Have you ever had a test? The British HIV Association, and now we're moving away from diagnostic testing more into screening. So that is more sort of the way we see it as a nurse's domain, but I'll come back to that in a second. They recommended that for everyone presenting to hospital admissions, or in fact anyone registering in primary care in an area where there's 2,000 or more population with diagnosed HIV should be offered a HIV test. And then this was supported by, and then kind of further investigated by the Department of Health. They did a few pilots across many testing sites, hospitals, communities, and 3 GP surgeries. But in a nutshell, it was found that offering a HIV test was feasible and acceptable to both staff and patients. Let me just share some very brief information on a project I was involved in in Hackney GP surgeries. So this is a clinical trial across Hackney surgeries, 40 Hackney surgeries. They were randomized into intervention and control surgeries. We looked at GPs received education about HIV, and then nurses and healthcare assistants were trained to offer the test as part of the new patient health check. That's the test kit we used. It's a finger prick test. It gives an answer in just 1 minute. Its sensitivity is very high, very good specificity. Anyone with what we call a reactive test result needs a confirmatory blood test from the arm. Quality assurance is quite a big thing. There's no more need for an in-depth counseling. This is what our healthcare system said. HIV is a chronic medical condition. That's before offering when offering the tests. Chronic medical condition. There's excellent treatment. It's better to catch it during early stages, and you can have partners and children. And that is just the data from the first 2 years. So the interesting thing is, 8,000 patients were offered a test. More than 3,500 tests were performed. 8 came back positive, confirmed HIV positive, and then the final figure is 11. Just going to skip that. This question comes up time and again. What about serology testing? What's the window period? How accurate is it? It's highly sensitive, but the modern assays are highly sensitive. Window period is 3 months. But if someone is at low risk and they have a negative test after 4 weeks, this is highly reassuring. And then the post-test, so this is the post-test discussion, the pre-test discussion. So what do we actually, when offering a test, what do we, how do I want the patient to know they have HIV? So in the way I usually ask them, the way I do is I just ask them, I assess the risk. If they're low risk, then I would say, well, how do you want to find out about the result? I mean, of course, it depends on how your surgery settings are. Do you want just to leave it, I want for it to be good news is good, is bad, good news is good news, no news is good news, or do you want to be informed? Do you want to leave a message on your phone? If someone has is at high risk, then the BIVA recommends that we arrange a face-to-face discussion. So that is people who are likely to have HIV, people with mental illness, people needing an interpreter, the very young, and people who are anxious. I'm just going to skip that. Okay, just 1 minute on routine shared HIV care. HIV care is clearly moving away from now that people are stable on the medication. Most people are stable on the medication. A lot of HIV care will be shifting towards general practice. The HIV population is aging. They're at an increased risk of suffering from cardiovascular disease. And so one thing is, at what stage do we start offering them an NHS health check? How do we share the cholesterol test result with the specialists? Because a lot of this is done in secondary care. Co-prescribing of drugs contraindicated in ART. I'd like to point you towards 3 really important drugs. Simvastatin is a complete no for any antiretroviral medication. And then some PPIs and steroid inhalers and nasal sprays interfere with proteinase inhibitors. And then, of course, there's a lot of suffering and of depression in people with HIV. They have a high risk of osteoporosis. They require annual flu vaccinations and an annual smear test. And then, maybe as my final point here, when meeting patients and living with HIV and their representatives, confidentiality is a very big issue. Okay, just in summary, HIV and migration are linked. Fear and stigma make things worse. The increased diagnosis requires knowledge of local HIV prevalence, recognition of HIV-associated illnesses, and the confidence in successfully offering a test. There would be you will eventually receive handouts with all this information and loads of references for you to look at. And then with the relentless shift of HIV care to general practice, I think there's quite a few things we would have to be aware on, but this is for us to figure out in the next year or so. Thank you.